webinar in Move Muscle, Bone and Joint Health 2017 Musculoskeletal Health webinar series. Our webinar series in the first half of the year will cover a range of topics, including our webinar tonight on neck pain and other issues such as management of low back pain, common foot problems, and pain management in people with inflammatory forms of arthritis. Details regarding these webinars can be found on our website and will also be sent to you. The recordings of previous webinars are also available. Before introducing our presenter for this evening, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the webinar organiser at Redback Conferencing. If you're listening via the phone, you'll notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions after the completion of her presentation, you can type questions for her at any time. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Summer Time. Also, I'd be very grateful if all participants could take a moment during question time to respond to our feedback survey. Our presenter for this evening is Gwendolen Jull. Gwen is Emeritus Professor in Physiotherapy at the University of Queensland. She is a specialist musculoskeletal physiotherapist and a fellow of the Australian College of Physiotherapists. Her research and clinical interests are in cervicogenic headache, whiplash-associated disorders, manual therapy, and quantifying the dysfunction in the cervical motor and sensory motor systems as a basis for therapeutic exercise in the rehabilitation of neck disorders. Gwen has published extensively in the field with over 300 publications, 40 book chapters, as well as 2 textbooks. She is the co-editor of the journal Musculoskeletal Science and Practice. Without further ado, I'll hand proceedings over to Gwen. Thanks very much, Gwen.
Thank you, Jen, and it's a pleasure to be here tonight and talk about this subject, which is dear to my heart, which is mechanical neck pain, and are we thinking about recurrences? Okay, Jeff, our first little problem. Can you advance the slide? It's a good place to start is looking at the prevalence of neck pain. About half of the adult population will complain of neck pain in any one year. But probably the statistic, advance it please, probably the statistic that concerns us most is neck pain which limits daily activity. And advance again. About 10%, or in other words, about 2.5 million Australians each year have neck pain. It actually affects their daily activities and their work productivity. Advance again. Oops, one more. This is the Neck Pain Task Force, and during the Bone and Joint Decade, they did many systematic reviews. And their conclusion when they overviewed neck pain was that the course of neck pain is best described as episodes occurring over a lifetime with variable degrees of recovery in between episodes. So in other words, it's a recurrent disorder. If we look at the RCT, looking at the management of acute neck pain, you'll see that their focus is on alleviating the acute episode of pain. And we can see that in their primary outcomes. They're all about pain. But if we look at another piece of work, which is the Global Burden of Disease Study, and we look at the top 10 of the 310 conditions studied in terms of years lived with a disability, suddenly we see that neck pain, along with low back pain, is #1. So even though an acute episode is important, the real burden and cost of neck pain are in their repeated episodes, repeated occasions of care, reduced productivity, reduced quality of life, and indeed costs of harm, such as the side effects of treatments as non-steroidal anti-inflammatory. So as I said, currently mechanical neck pain tends to be treated and regarded as a series of single episodes. But I really do think that this focus on single episodes masks the need to focus on the real problem, and the real problem is the recurrent nature of neck pain. So if we're going to think and have a focus on decreasing recurrence rates and limiting the progression to chronicity, then we've got to think, I think, about is adequate rehabilitation. And when I think about adequate rehabilitation, I'm referring to things like restoring neuromuscular control, restoring sensory motor control, optimising a patient's work habits, and certainly lifestyle education. Now, patients desire pain relief. So in focusing on recurrent episodes, I'm not denying that pain relief is a very necessary and desired outcome. But we've also got to think of primary prevention, so that's public health, and secondary prevention. And as I mentioned, secondary prevention is talking about appropriate rehabilitation. Now, these are almost my excuses for focusing just on one thing, which is the rehab of the muscle system, etc. And I certainly acknowledge that many factors are likely to contribute to neck pain recurrence. And we think about neck pain within the biopsychosocial model. And at this point in time, no intervention has been shown to decrease recurrence rates. But I'd like to propose that adequate rehabilitation of neuromuscular and sensory motor control could make a substantial contribution to decreasing this recurrence rate and tendency for transition to chronicity. Now, in relation to the muscle system, over the last 10 to 20 years, we've all gathered a huge amount of evidence that neck pain causes an array of changes in neuromuscular and sensory motor function. And before I pursue that argument, I actually just want to talk about one impairment. And the reason I'm talking about this one impairment is I'll use it as an example as we go through this talk. What we've been able to show in research is that there's an altered pattern of behaviour between the deep and superficial muscle layers of the neck. And it occurs in both the flexors and the extensors. Sorry, there's been more research on the flexors, but certainly these changes are coming through on the extensors. But we have this simple muscle test called the Cranio-Cervical Flexion test that allows some differential testing of the layers of the neck flexors. So cranio-cervical flexion targets the anatomical action of the deep neck flexors. It's not the action of the superficial flexors. Muscles like sternocleidomastoid are powerful flexors of the neck, but they actually don't flex the cranio-cervical region, or they don't flex the head on the neck. So it's also low load, so it allows some muscle specificity. Now we saw that little pressure biofeedback behind the neck, and that's because the task is that we ask the patient to be able to nod their chin to progressive inner range positions, which we denote by the pressure changes of 24, 26, 28, etc. But as you can see in this slide, for the deep neck flexors, which is the top tracing, within a healthy participant, we get quite good activity of the deep neck flexors as per our anatomical prediction. And you can also see on the other lines, which are anterior scalenes and sternocleidomastoids, that there's very little activity as you would predict anatomically. But if we look at a patient with neck pain, you can see that the deep cervical flexors, that top line, they're almost flatlining. And the patient is now using muscles such as their anterior scalenes and sternocleidomastoids to do the task. We've asked them to do a task, so they've got to use whatever strategy they can to use it. And so you can see that there's this totally different pattern between our healthy participants and our participants with neck pain. Now, putting those into a graph, and I'm afraid, sorry, the colours haven't come out, but on the left, for the deep cervical flexors, the top line represents the normal population, the healthy group. So you can see that with progressive inner range contractions, that they have more sternocleidomastoid activity. And then the control group is the bottom line on the right-hand side of the graph. In other words, they don't use too much sternocleidomastoid. In contrast, our neck pain group, so that's the bottom line on the left-hand graph, they can't activate their deep neck flexors, and then on the right-hand side of the graph, you can see that they tend to use too much sternocleidomastoid. Now, we've also shown that there's a moderate inverse relationship between the activity of the deep neck flexors and sternocleidomastoid. And putting that simply, what that means is that the more deep neck flexors they use, the less sternocleidomastoid they use, or the less deep neck flexor activity, the more the sternocleidomastoid activity. And that's an important relationship because in clinical practice and in a lot of our clinical research, we have only looked at activity in the superficial flexors. We had to use a nasopharyngeal catheter to insert a surface electrode to gauge the activity in the deep neck flexors, and I can guarantee you patients don't like it terribly much. So we use only the activity of the sternocleidomastoid. So looking at that right graph, what we're seeing is that neck pain patients have more activity compared to our healthy controls. Now, we've done research on many different neck pain groups. And as you can see here, our neck pain groups are the ones at the top. So they have more activity than our control group. And interestingly enough, it didn't matter what condition we looked at, whether it was neck headache or whiplash or mechanical neck pain, occupational neck pain, it didn't matter. We kept finding this same thing, that patients were weak in their deep neck flexors. And when you think about it, it's probably not too surprising because thinking of a patient with a knee joint problem, it doesn't really matter what pathology that they've got. You'll always know that you'll find problems with their quadriceps and particularly their VMO. So it's almost like the deep neck flexors are the VMO of the neck. So let's get back to where we were, and I'll be showing you some of those slides. So we know that neck pain causes changes in the neuromuscular and sensory motor functions, and a lot of different changes. But what the evidence also suggests is that this impairment in muscle function and in sensory motor control does not automatically return to normal just with pain relief. And we can see this in this longitudinal study of whiplash. So the bottom line is the control group, and the other three lines are the patients with neck pain. So you can see that they've got that abnormal pattern of activity in their sternocleidomastoid. But the one to note is the one that's got the red circle around it, because that group of patients said at 3 months that they were fine, that their neck had recovered, that they had no pain, and yet their muscle function had not returned to normal. Likewise, in the headache trial that we did many moons ago, the manipulative therapy group got excellent relief of neck pain, but see, circled in red again, their muscle function did not get better. It was only the two groups above who received exercise who actually improved their muscle performance. And this is a more contemporary study done by Kiki Lush from Spain. But again, he found that manual therapy effectively reduced their neck pain, but as you can see on the graph, it didn't change the activity in sternocleidomastoid or the anterior scalene. Whereas, as you can see with the graph on the left, the pre-treatment, the EMG activity was high, and then post-exercise, they had reduced the activity in these muscles, which means that they'd improved the contraction of the deep neck flexors. So in other words, pain relief does not mean that they get automatic restoration of muscle function. And I would suggest that this could be a contributor to recurrent episodes. And that backs my suggestion that we should have specific muscle training in our rehabilitation program. Now, there are other symptoms that we can get with neck disorders, such as lightheadedness and dizziness, unsteadiness, visual disturbances. And the physical impairments that are associated with those symptoms include impaired joint position sense or movement sense, impaired balance and eye movement control. And there's a good study done by Sue Reed on patients with cervical vertigo. And what she showed that, again, the two groups who received manual therapy, the black is the control group who had no treatment. So the two groups who received manual therapy got relief of their symptoms of dizziness. Okay, so symptomatic relief. But when we look at the changes in the impairments, and they measured joint position, accuracy and balance, as you can see with that graph on the right, you've virtually got a straight line. So they got no improvement in impairment. So again, decreasing the symptoms doesn't mean that they automatically get improvement in their impairment. And again, I think that this is one of the contributors to recurrence. And again, it suggests that we've got to do specific training as well as being concerned about decreasing pain. As I said, pain relief is important, but if we're thinking about prevention of recurrence, that says that our management program has got to include a comprehensive exercise program, and also that we've got to ensure that the changes in neuromuscular and sensory-motor function are reversed and are restored to within normal limits. Now, you might say to me, well, heaps of clinical trials have tested the effects of exercise, but if you look at these RCTs and you look at what are the primary outcomes, the primary outcomes in the main are pain. They're not really considering whether the neuromuscular impairment has been addressed. And I would suggest if we're looking at the effects of exercise on normalising neuromuscular function, the right outcome measures are not being measured in these clinical trials. So let's think about the nature of exercise. And really, what exercise you do depends on what your primary outcome is. Now, if pain is your outcome of interest, and that's the only outcome you're interested in, then in fact, any exercise can be prescribed. And that was shown very clearly in two trials treating patients with neck pain and headache. One used a very low-load motor control training regime, and the other trial used the exact opposite. They used a high-load strengthening. So both trials got similar outcomes. I'm going to suggest that if the primary outcome of interest is restoring muscle function towards prevention of recurrence, it does matter what exercise is prescribed. Let's just take a second out to look at the function of the neck muscles. So very, very basically, the function of the neck muscles is to support the weight of the head and coordinate the movement of the head to vision. So really, the reason that we move is to subserve our vision. Now, all muscles of the neck work together for these functions, but there is some specificity in the function of the different layers of the neck muscles. So you can see the sternocleidomastoid there in front, in the black. Now, that's a very important muscle, and in fact, it's one of the ones that holds the weight of the head against gravity. And if we want to, for example, lift our head off the bed, 87% of that flexor torque is supplied by sternocleidomastoid. And we can see at the back another muscle in black, which is the Splenius Capitis. Again, its primary role is to support the load of the head. But as you can see, both of those muscles, their attachment is nowhere near the actual cervical segment. So even though they can support the weight of the head and carry that load, they actually can't support at the segmental level. And so in synergy with them, we've got this deep layer of muscle that literally does surround the vertebral column. So we've got muscles at the front, as longus capitis and longus coli, and at the back, muscles like multifidus and semispinalis cervicus. They really do form a muscle sleeve surrounding the cervical segment. And so you can see that we've got this good interplay between the superficial and the deep muscles to have adequate function. Now, what I'd like to do now is to explore some examples of impairment to further this argument that it does matter what exercise is prescribed. So we saw that before, where our neck pain patients couldn't activate their longus capitis and longus coli. So what's the functional ramification of that? Longus coli is one of the major muscles that actually controls the angle of the cervical curve. And when we sit, that requires tonic low-level endurance of the longus coli. But we've got evidence from a couple of different studies now, the one from Zito from Hong Kong as well as the one of our own by Fella, that people with neck pain who have the poor deep neck flexors, when they work at a computer, they drift into a more forward head posture because they just haven't got that control. And then, as all physio knows, that forward head posture is known as the big evil posture, and it isn't a good posture because it puts the upper cervical joints into extension. And we also know in a forward head slump posture that there's higher neck extensor activity in this position. So in other words, that puts more compressive loads on joints that are already into extension. So it is very much a potentially pain provocative posture. What's another functional activity? And we think of reaching. Now, every time we move our arm or we lift something, our joints of our necks move. And you can see that in this graph, that it was an MRI study done by Takasaki. And what he did was put a 2 kilo resistance at 0 degrees abduction, 30, 60, 90 degrees abduction, and then measured the displacement of the vertebra. So you can see that every time we want to lift or move with our hand, that the neck muscle, the neck joints will move. And by the way, that is a very normal occurrence, and we need it to distribute the force and to absorb shock from the forces of the upper limb onto the neck. So it's normal. But the other thing we've got to take into consideration is that neck pain changes the way the brain coordinates the muscles. So we can see in this healthy participant, and up at the top is AD, anterior deltoid, so the onset of the EMG activity corresponds with the movement of the arm. So what you can see is that the instant the arm moves, all of the neck muscles, the deep cervical flexors, anterior scalene, sternocleidomastoids, they all come in. But if you look at the neck pain participant, and you can see there on the top line that the anterior deltoid, it comes in, but then there's a delay for when the neck muscles come in. So hold that thought. We're seeing the same thing, by the way. So both of those, we were looking at the perturbation being from the arm, and this one by Bordeaux and Fella had the perturbation down at the base of the feet. But it was exactly the same sort of situation. If you look at the sternocleidomastoid and you can see the open part of the graph, that's indicating that the neck pain patients had a delay in their onset of sternocleidomastoid. And there was a bit of dependency on which way the platform was tilted or slid. But basically they found the same thing, having a bottom-up perturbation as we had with an arm perturbation. So why do I get concerned about these altered muscle behaviours? Well, we know that one set of muscles for the control of posture and also for the control of movement, neither muscle can do it well. But unfortunately, in neck pain patients, they haven't got that deep muscle support, just in their support of their daily postures and movement of the neck. We just saw that the segments move every time we move our arms. We also just saw that those movements occur before the muscles come in to protect. We saw in the normal subjects that the muscles came in instantly. So they are in a feed-forward way there, supporting the joints to also help absorb force. But in the neck pain patients, their onset is delayed. So in other words, any strain has already gone onto those joints before the muscles come in. So it's not surprising that 80% of neck pain patients report neck pain with arm activity. Just remember that graph. Now, we've talked about those muscle coordination problems, but there's also many, many studies that have shown that the neck pain patients demonstrate reduced strength, reduced endurance and greater fatigability. So getting back to this comment that it does matter what exercise is prescribed, what I'd like to briefly talk about now is some clinical trials that we have done where we've researched into the physiological effects of different modes of exercise. So in other words, we looked at low-load motor learning, we looked at high-load strength and endurance training, and we also looked at mobility training. And then what we did was we took each of those impairments and the question was, well, which mode of exercise helps that impairment? And we used the flexors as our model to evaluate the physiological effects. And I can explain why later if you like. But the first outcome is that performance in the craniocervical flexion test. And if you look into the left two graphs, you can see that in the red, the patients couldn't activate their deep neck flexors to start with, and on the right, they were using too much sternocleidomastoid. But you can see after the training, using the low-load motor relearning, they could then, on the left, activate their deep neck flexors, and on the right, have decreased sternocleidomastoid activity. So in other words, they had restored that normal pattern of muscle behaviour. Looking on the right, the strengthening regime made no difference to that altered muscle behaviour between the layers. And we can also look at the second study, a different study that was done by Sean O'Leary of our group. And again, he found exactly the same thing, that on the left, strength training didn't change the pattern. On the right, mobility training didn't change the pattern, but the low-load motor learning decreased that sternocleidomastoid, as we found with the first study. So it could normalise the pattern. And when we look at that relative latency or the delay, we can see that in 80 to 90% of patients, the motor relearning improved the onset, the timing of onset. Whereas with the strengthening exercise, it was pretty well 50-50. Okay, in other words, if there was an improvement, it was pretty well by chance. Then if we look at strength and endurance, it won't surprise you that the low-load motor relearning program made no difference whatsoever to their strength. If you want to increase strength, then you've got to have load. And the same in O'Leary's study, that as you can see that with the red and the green lines on the bottom, that motor relearning and mobility, again, didn't really affect their strength and endurance. You needed strength and endurance exercises. Then lastly, we look at range of motion. And I think this is interesting because the green is the mobility exercises, and in fact, all other exercises seem to do better with mobility than the actual mobility exercises. So the outcome of these trials, I think, provide pretty convincing evidence that specific impairments are addressed by specific modes of training. There's no one-size-fits-all exercise if we're looking at restoring neuromuscular control. And the other thing that I thought was very, very interesting was the lack of effect of mobility exercises on muscle function. So we know that different types of exercises are needed for the different muscle impairments, and the same, I can assure you, is the same for the sensory motor impairment. So if we start thinking about reducing recurrence rates, as yet, lessening recurrence, as you've seen, has not been the primary outcome or objective of any RCT. And indeed, that's got to be the next thing. We need RCTs to try to test the effect of reversing this neuromuscular and sensory motor impairment to see if we can reverse them. Does that influence recurrence rate? But if we're going to design a trial for prevention of recurrence, there's a few things that we certainly have to think about. And we have to change the patient and practitioner mindset that the neck is better when pain eases. The pain may get better, but we know that the neuromuscular function has not automatically returned to normal. We've got to be able to design an appropriate management program, and I think we've got the evidence to be able to design a pretty good program. We know that appropriate exercise modes must be used to address the particular impairment. So therefore, we're going to have a multimodal exercise program. And indeed, that should be embedded in multimodal management, whether that's manual therapy, exercise, our ergonomics, etc. They're all quite important. The next thing we've got to think about is dosage. And what dosage of exercise do we need to eliminate the impairment? And this is where more work's got to be done, because the evidence here for the neck is not strong, What we do know is that if you want to restore the muscle coordination, it can take anything from 2 to 10 weeks. We've done a couple of pilot patients looking at trying to train the neck flexors to improve that onset back to normal. And we think that probably you can do it with exercise, but it takes at least 12 weeks of training for most people. And then if we want to do strength training, we're going to need up to 20 weeks of training to increase strength. And again, if you think of some of the health insurance companies, etc., if we're about to tell them that we want to treat this patient for 20 weeks, they're probably going to have a little bit of a fit. Although what is frustrating, if somebody tears their anterior cruciate ligament, there is no question that they'll need 6 months of rehabilitation. You injure your neck, there's great questions if you want 6 months of rehab. The other months of rehab. The other issues are compliance. We're certainly going to have strategies to encourage patient compliance, because the neck pain will get better before function is restored, and we must have relevant outcome measures. So the primary outcome will be the effect on recurrence, not just pain. We're going to need a long follow-up to really get an idea of recurrence. And then we've also got to have outcome measures of motor and sensory motor impairment to make sure that the exercises that we're doing are in fact bringing these features back to a normal range. And obviously appropriate cost-benefit analysis. Okay, before I finish, I'd just like to say a couple of words about translation to primary prevention, or in other words, a public health program, because primary prevention is in fact our best bet. Now, the burden of neck pain, unfortunately, is growing, and we saw that in the Global Burden of Disease study. The publication of the last iteration was 2 years ago, and there, neck pain was number 4. Now, the publication last year, it's risen to number 1. And we've got a lot of things, our ageing population, contemporary occupational influences. In many cases, we're becoming more sedentary, and also lifestyle influences, where we see everybody now has a bowed head most of the time. And what you've also got to remember is that the mechanical demand on the neck extensor muscle increases 3 to 5 times if you head forward using a tablet compared to looking forward in a neutral postural position. So again, there's a lot of education that's required out there. So with prevention, with the public health focus, we've got to emphasise healthy lifestyles and correct exercise regimes. Now, currently, if a person consults Dr. Google about what sort of exercise that they should do for their neck pain, this is what commonly comes up. So the current face of exercise for neck pain is mainly mobility exercises and stretching exercises. And we've just seen that these sorts of exercise have absolutely no effect on muscle control, and they have very little effect. Well, they do affect range of movement, but other exercises actually improve range of motion better. So what the public is currently seeing for management of neck pain is certainly not best evidence-based practice, and that's something that we have to address. So what are the other attributes of a public health program? It's got to be safe, it's got to be short, simple, and effective. And also, it's got to be able to be compliant. We've got to be able to incorporate whatever the strategies are into daily activity, and it's got to be a strategy that people of all ages can and will adopt, from children to the elderly. Now, importantly, it has got to be simple, and I'm going to offer you one exercise. This is the most non-evidence-based talk that I'm giving now, but from clinical experience, maybe one of the best maintenance or prevention exercises could be postural correction. What we have shown is that when we facilitate a patient up to a neutral postural position, it does in fact activate their deep stability muscles. If we ask them to do a manoeuvre such as try to lengthen the back of your neck, you get a real burst of activity in longus coli. And so the exercise itself is starting to train those supporting muscles, and particularly the deep muscles. The other advantage about a postural correction is it puts the joints of the spine into a neutral position, so that takes off the load and makes them most comfortable. And what we advocate in clinical practice is that patients practice that for 10 seconds twice an hour. And the study that you can see there that we undertook showed that if people did it twice an hour for 10-second holds and did it for about 8 hours of the working day, that successfully kept or re-educated their deep stability muscles. So maybe we don't have to be too sophisticated. I think, in fact, we have to be very, very simple. And I always have great admiration for the dental profession, because they're the ones who have got a public health preventative program that pretty well everybody in the world undertakes once or twice a day at least, and that is cleaning your teeth. So something like the postural correction exercise, maybe we can liken it to cleaning your teeth that you must do every day. So to remind you, when we're starting thinking about episodic versus recurrent neck pain, that the latest study shows that neck pain is #1 of 310 chronic conditions in terms of years lived with a disability. So gaining relief from neck pain, from an episode of neck pain, is important, and there's no doubt about that. But a focus on relief of pain only is unlikely to impact on recurrence rate and the burden of neck pain. So I think that if we are wanting to address this, that we've got to have appropriate rehabilitation of the muscle system and good work and lifestyle habits. And I think that is likely to have the best chance to impact on recurrent rates and that burden of neck pain. And then akin with that, we need an evidence-informed public health strategy to impact. Prevention is always, as we well know, better than a cure. So thank you very much. And when you do research into the area, you never research by yourself. So I'd like to acknowledge the researchers at the UQ Cervical Spine Research Unit, and also our international collaborators and the contributions of our PhD students. So thank you very much.
Well, thank you, Gwen, for really a fascinating presentation. It's so interesting, and it certainly made me sit up straight towards the end. We've got quite a few questions that have come through, and I would ask anyone who wants to pose a question to type it in now. While we're going through the questions, you'll also notice there has been an exit or a feedback survey come up on the screen. So if you could complete that while we're running through the questions and when responding, I'd be very grateful. Gwen, you may have answered this question with regards to your postural correction exercise just before, but there's a question, what are the specific exercises to train and strengthen the longus coli muscles?
Okay, well, we start off, just as that you saw that slide with the person lying down, we start off training it by training that head nod action. And we also train their endurance capacity. Now, this is getting very into sort of physio language, but we use that biofeedback to give the patient feedback of why we need it is people can't feel their longus coli, it's too deep, and we can't palpate it with any accuracy. So it does give them feedback of performance. It looks a very simple exercise, but when they get feedback on their accuracy you pick up that it's quite a challenge for many of your neck pain patients. But to make it simple, basically we retrain their ability to nod their head and to be able to hold an inner range position, so it's their endurance capacity that we want to train, to hold their inner range position, and it's an arbitrary 10 by 10 second hold. And then we'll progress to strengthening it in a head lift exercise where all the emphasis is on controlling your head position. But we do the first low-level training first, improve their endurance, and then progress to a strengthening exercise.
And Gwen, just a question, can you please give some examples of high-load strength training exercises for the neck?
Well, the simplest ones are head lifts, basically. They're the simplest ones that you can use. And you can start off by getting the patient to do controlled head lifts, sitting in a chair with their head resting against the wall. And in that position, you've got less gravity acting, and so it's easier. So you can bring in some progressive load by having the chair very close to the wall to start with, and then gradually progressing it so that it's about 20 centimetres. Oh no, not 20. I'm thinking I've got to speak in inches still. Till it's about 6 or 8 inches away from the wall, and that's about as much as they can take. So you've increased gravity as you take the chair further from the wall. And then we put them on to lying on, for example, 2 pillows on a bed, and they practice the head lift. The most important thing in any sort of head lift is that they control chin position. They've got to be able to nod their chin and hold their chin down as they lift. If you see people trying to lift and their head or chin pokes out, you know that you've actually given them too much resistance. Their deep neck flexors can't control their head position, so you've got to back off. And then, so often in clinic, if you want to be non-sophisticated, you can just use the head lift exercises, but if you want to get into, you can use TheraBand resistance. Some of the gymnasiums have dynamometers and different machinery that you can do resistance. I mean, the strength training is really to whatever demand that the patient has. So, for example, if you're going to play a lock in a rugby union scrum, you're going to strengthen and you're going to hypertrophy and you're going to do everything in the world for that. But if you've got a patient whose occupation is sedentary on a computer, their exercise is walking regularly, etc., I mean, they're never going to use more than about 5% of their maximum capacity in any of their work or recreational tasks. So often the head lifts off a couple of pillows is as much as their functional demands would ever be for their neck.
And Gwen, some examples of endurance exercises for the neck?
Time. Time is the best. So for example, in training the deep neck flexors, we'll get them to hold the positions, you know, hold the chin tuck or to hold the nod position of the chin, and they'll hold it and they'll do our traditional 10 by 10 second time. So endurance in that is usually by time. The same thing with the extensors. We get them to hold, but the extensors we also train them in repetitions. So it's time and repetitions for endurance really, and then you can decide at what load you want to do that. So you'd start off at a very, very low load, and then as the patient requires, you progress the load that you do the holds and the repetitions.
And with the protocol for measuring motor relearning, what types of exercises did this include? As someone was just inquiring about that.
Well, what we're trying to do then, what we're trying to do in the motor relearning is to target. If you can think of skill training, and that I want to hit a golf ball, for example. So you'll often break down the skill and train some of the component parts and then put it all back together again. So what we do in this motor relearning is we break it down. So for example, I'll use the deep neck flexors yet again. We'll train those out of function. The patient's lying on the bed and they really concentrate to be able to control their neck flexion or their head flexion and to be able to hold hold that position. And then once they can start to activate and hold that, we'll then start to train within function so that they'll train in the postural correction, for example, that they can hold that postural correction. And then they'll train that they can hold that postural correction while we add load through upper limb activities, for example. And then we'll progress that on to addressing their strength and endurance deficit. So it's like any sort of skill learning. You take them out of function, train the components, put it back into function.
And Gwen, exercises to improve sensory motor function.
Well, that depends. That depends on what impairment the patient has. So what the impairments that they can get, for example, are proprioceptive. In other words, they lose their ability or what we call reposition sense and movement sense. So, for example, we would get them to train being able to start in a neutral position, turning to the right, for example, and then they've got to bring themselves back to that neutral position. So they'll just practice that reposition from rotation, from extension, etc. And they may practice to start with their eyes open so that they can see what task, and then they've got to practice with their eyes closed. We often give them a laser that they put on their head so that they can get feedback from the laser. With any of this sort of sensory motor testing, training rather, and motor control training, feedback is a really essential ingredient of it. So that they might practice that repositioning so that they can reposition accurately. The other thing that people lose is that they lose the control, the fine control of movement. And so again, we can use those lasers, and they start tracing different, well, they might just trace a square to start with, trace a zigzag pattern, trace circle pattern, so that you start improving their accuracy of movement. And then the other thing that we might do with sensory motor control is improve their speed or their velocity of movement, because interestingly, it's common sense when you think about it, they find that the most functional deficit is not so much in your range of motion, it's in your velocity of motion. So if you can imagine that you're driving and you want to check that whether a car's coming, you only need about 45 degrees to do that. So if you've got 45, 50 degrees of rotation or 60 degrees of rotation, you can do it. But if you can't move fast, that is functionally more debilitating than whether you've got 50 or 60 degrees of motion. So that you can also use to train movement velocity. And you can use things, again, as simply as targeting targets with a laser, and you've got to do it at a greater speed, etc. The other, and by the way, I've given simple examples, but there are quite sophisticated or increasingly sophisticated methods out there. Virtual reality is being done so that you can practice your movement accuracy, etc. There's lots of different ways you can do it. Other things that you might have to train is balance, and I think that's the thing that's astounded me so much. 20 years ago, I wouldn't have thought of testing a neck pain patient's balance. But once we started researching this thing, and you'll take it to the clinic and have a look at the patient, and it is surprising how much balance is affected by neck pain. It shouldn't be surprising. I mean, there's direct links, to the vestibular system, to the visual system, etc., to the somatosensory system, so we shouldn't be surprised. But balance often needs to be trained, and again, that can be done in a relatively straightforward way of training them in narrow stance, in tandem stance. You've often got to progress the neck pain patient, so it can be with eyes closed, standing on foam, standing on unstable surfaces, etc. as you go. And then the other one is that happens in sensory motor is a lot of the patients with neck pain often say, I find it difficulty focusing. They often find that it's difficult to focus, etc. And so that often is related to deficits in maybe eye follow. It's eye follow. If they've got eye-head coordination, that can often be the problem, and so you'll do exercises that help improve their eye-head coordination, such as gaze stability exercises, eye follow exercises, etc. A bit similar to what you do in the vestibular rehab program.
When we've still got a couple of questions to go, and I'd urge anyone else who wants to ask a question to type it in as we're approaching the end of our time this evening. Someone just was wanting to run through that schedule with the postural correction schedule that you, I think it was 10 seconds twice within the hour, is that correct?
Yeah. Personally, I always ask patients to do double. So what we ask them to do is to literally grow tall, and they've got to try to get that pelvis. That's one of the major things, to get their pelvis into an upright, neutral posture. So they grow tall, and then the second aspect of it is that they feel that they're elongating the back of their neck. Now, they've only got to hold it. So it shouldn't be a thing that I keep advocating to the patients use a 10% effort. So it's not strong, it's more that little bit of accuracy to get yourself up there, get the elongation at the back of your neck. And then they only need to hold it for 10 seconds. And then I usually ask them to do it every 15 minutes, knowing that patients will probably do it at about half what you've recommended. And we showed in that study that if you do it twice an hour, those patients got their improvement by doing it. We did a record of compliance. They got their improvement by doing it twice an hour for 8 hours of the day. So I will tend to ask patients to do it every 15 minutes for their waking hours, knowing that I'll be lucky if they do it half. But I also know that if they do it twice for 8 hours a day, that they will get the therapeutic effect of doing it. But it's also getting them out of the posture. But again, your main challenge with them, the main challenge of the exercise, is nothing difficult about the exercise. There is, you can do it sitting, you can do it standing, you can do it walking, you just grow tall basically. It's compliance. It's getting the patient to remember to do it. And so you've always got to get them to think of things that they could do to remind them every half hour to actually do it. So some people will say that they'll put a little reminder on their watch or their smartphone or whatever, but just get them to think about what will remind them to do it. It takes nothing to do it. It's very, very easy. They can continue their work. They can continue driving and do it, etc. So it's just remembering to do it.
And Gwen, with regards to that postural correction with a patient with neck pain, how many days would you sort of suggest it should be completed before changes and improvements might be seen?
Oh, look, I can't answer the question really, because it's very, very variable. I mean, neck pain patients, one of the greatest characteristics is that they are so variable in their presentations and in the magnitude of what's going on. And it's terrible to tell clinical stories, but to tell a clinical story, I think they should see change within a week to 2 weeks, okay? If they can, I've had patients who have gone away and done it really conscientiously and have made not cures, not relieving pain, but noticeable differences within a week or two. So if you just keep deloading, okay, it's not a miracle cure, by the way, but it can certainly contribute to anybody's neck pain if they conscientiously do that. I'm sure of that.
And also, do you have an opinion on isometric neck strengthening exercises?
Sure. I mean, isometrics are fine. I like isometrics with rotation, and that's part of a rehab program because rotation gives you a co-contraction, and if you think about that deep muscle sleeve surrounding the vertebral column, you want a co-contraction of those deep flexors and extensors. So an exercise that I commonly give is an isometric hold using a rotary resistance. But again, I'll tend at the beginning to only use it at about 10 or 15% effort so that I concentrated on those deep muscles. Just one other important thing, when they do the isometric, just make sure that they are in a good posture, because if they're sitting there with their head poked forward and do an isometric rotation, you're actually facilitating all the wrong muscles. So make sure they're in a good postural position and then do your isometric. And I've got no objection to doing isometric flexors and extensors. I just think rotation gets the flexors and extensors co-contracting. And if you keep it more at the low load, you'll aim it better at the deep muscles.
And one last question from me, Gwen. You mentioned about the importance of education for patients. So certainly you mentioned about the importance of education for patients. So certainly you talked about primary prevention and the broader public health campaigns. Then what might be some elements included in a sort of a broader lifestyle education for a person with neck pain and under management for neck pain?
I think it's important to explain what their pain is all about. Explain pain seems to be an India expression at the moment, but I think you need to explain the pain, why they're in pain, and where's the pain coming from, and how it is processed. I think even though there's not a lot of education, there's not a lot of evidence that if you educate them on anatomy biomechanics, it has any major effect. I still think that it's important that they do understand some basic biomechanics. Just for example, the loads on there, when they sit in a slump posture, the loads on their neck. So I think the education needs to be about pain. I think it needs to be about a little bit of biomechanics. And then the education, I think, needs to be in a problem-solving sort of way, so that the patients can work out alternative ways of doing things if certain things actually hurt their neck. There's no purpose in deliberately doing things that deliberately hurt your neck. You've got to work out ways that you can work without strain on your neck. So I think it's the combination of those things.
Thanks, Gwen. And can I just urge people, if you haven't completed the survey on your screens at the moment, that would be great to do so. We'll no further questions this evening. So on that note, we'll close. Gwen, that was so interesting and so comprehensive. So I thank you on behalf of Move Muscle, Bone and Joint Health. And I also thank everyone who has participated this evening. Can I please remind you you'll receive information about our forthcoming webinar in April, which will be on the management of low back pain. And we're very lucky also to have Professor Peter O'Sullivan from Curtin University presenting that webinar. So on that night, I'll say good night to all our audience. And Gwen, thanks so much. Good night, and many thanks to you as well. Good night, everyone.